Good day, dearest great surgeon. Today we gonna talk about microbiology. We will make this chapter simple and concise and to the point as much as possible to save your time. Hope you enjoy your time and let's go with microbiology.
Macrolides act by inhibiting bacterial protein synthesis. They can be called bacteriostatic in nature, but in reality, this depends on the dosage and the type of organism being treated. And let's take for example the erythromycin, which is the first macrolide used clinically. More recent examples like clarithromycin and erythromycin. The adverse effect of erythromycin includes gastrointestinal side effect and cholestatic jaundice and B40 inhibitor, B440 450 inhibitor. Fasciola hepatica is most classically transported to human through eating watercress. Watercress is not a job, it's a food. It's a green herb, الجرجير بالعربي. The ultrasound finding of luminal parasite is clinical and classical and is contribute to jaundice. More important note about Fasciola hepatica. It's also known as common liver fluke. It's a parasite trematode. Infect human as a part of plant or food trematode infection. Found throughout the whole world, and there are two illness phases. During the acute phase, the immature worm begins penetrating the gut, causing symptoms of fever, nausea, swollen liver, skin rash, and extreme abdominal pain. The chronic phase occurs when the worm matures in the bile duct and can cause symptoms of intermittent pain, jaundice, and anemia. Diagnosis is either by stool sampling or serology. The treatment is with triclabendazole, and some patients may need ERCP. The cell cycle of the fasciola. We have the cattle or the sheep, bathe their faces with unembryonated egg. Then the embryonated egg bathes in water, and the Basidia hatch penetrating the snail, and the snail, free-swimming Cercaria, insist on water plant. The man will eat the plant, and the sheep will eat the plant, and here the cycle goes on. So, this is how the man got infected from the watercress. The sheep buys the stool with unembryonated egg, and the stool with the unembryonated egg takes its cycle to infect the green herb, which the man eat, like the watercress. Clostridium perfringens is a common cause of foodborne illness, and its ability to form spores make it relatively resistant to cooking. And the time onset is very important in diagnosing the causative organism. In a matter of hours, over several hours, the Clostridium perfringens will typically evolve within those hours, rather than the Staph aureus, which will occur sooner. Escherichia coli, the E. coli is gram-negative electrode, facultative anaerobe, non-spore forming, has many subtypes. Some subtypes like O157 may produce lethal toxin result in hemolytic uremic syndrome. The enterotoxigenic E. coli produce enterotoxin, the ST enterotoxin, that result in large volume fluid secretion into the gut lumen via the cyclic GMP, binding to intestinal cell and cause structural damage that coupled with moderate to severe invasive component produce enteritis and large volume diarrhea together with fever. They are resistant to many antibiotics used to treat gram-positive infection and acquire resistance rapidly and are recognized as producing beta-lactamase. Streptococcus bovis septicemia must remind you of carcinoma of the colon. It can also cause endocarditis. So, Streptococcus bovis septicemia associated with carcinoma of the colon and carditis. Campylobacter jejuni. It's a curved, gram-negative, non-sporulating bacteria. It's one of the most common causes of diarrhea worldwide. Produces enteritis, which is often diffuse and bloody. So it's a bloody diarrhea, bloody diffuse diarrhea. Remain in differential of right iliac fossa pain with diarrhea. Self-limiting infection to antibiotics are not usually advised. However, the quinolones are often rapidly effective. This is the Campylobacter jejuni. Let's be familiar with some definitions like Melanie, Fournier, and necrotizing fasciitis. Necrotizing fasciitis is advancing soft tissue infection associated with fascial necrosis. It's uncommon but can be fatal. In many cases, there is underlying background of immunosuppression like diabetes. Causes of polymicrobial flora, aerobic and anaerobic, and Mrsa is seen increasingly in cases of necrotizing fasciitis. Streptococcus is the commonest organism isolated pathogen infection, about 15%. Merinii gangrene. Merinii is a similar principle of necrotizing fasciitis, but the infection is more superficial-sided than necrotizing fasciitis and often confined to the trunk. Fournier gangrene. It's necrotizing fasciitis affecting the perineum. It's a polymicrobial with E. coli and Bacteroides acting in synergy. But the Fournier gangrene only eats the skin of the scrotum and doesn't affect the testicle. Always spare the testicles. How would we manage either necrotizing fasciitis, Merinii, or Fournier gangrene? It requires a radical surgical debridement. Radical, complete, aggressive surgical debridement forms the cornerstone of the management. Sterile dressing is used to dress the wound, and reconstructive surgery will be considered once the infection is completely treated. When you hear about diarrhea in an immunocompromised patient for 3 months duration, you have to think out of the box, out of the normal, because the immunocompromised individual who can develop severe illness will most commonly be affected by the non-common, the opportunistic, like Cryptosporidium, and the other opportunistic like Salmonella, Shigella, and Campylobacter. The passage of very loose and watery stool distinguish cholera. Most gastroenteric infection doesn't produce such watery motion except for cholera, most common with cholera. Vibrio cholera, short gram-negative road, transmitted by contaminated water and seafood. Symptoms include sudden onset of effortless vomiting and profuse watery diarrhea. Correction of fluid and electrolyte loss are the mainstay of the treatment. Most cases will resolve. Antibiotics are not generally indicated in Vibrio cholera infection. In surgical ward, Clostridium difficile can spread rapidly, so take care of the scenario of the question. I know you may read profuse watery diarrhea spread in the hospital ward. How come Vibrio cholera be in the hospital? It's not logic. So think of the scenario. Clostridium difficile can spread rapidly on the surgical ward. The use of broad-spectrum prophylactic antibiotic during arthroplasty surgery can increase the risk. The beautiful thing regarding MRCS, it reminds us of the microbiology for real. Many of us know the syphilis and forgot that Treponema pallidum is the organism causing for syphilis. It's a venereal syphilis caused by the spirochete Treponema pallidum. The hard painless ulcer affecting the genital area of a young male is likely to be not iatrogenic and not all of a sudden, but may be due to primary lesion of syphilis, and that is caused by Treponema pallidum. It would be unusual for actinomycosis to affect this area to a well-fit man. The individuals who are not treated from syphilis will eventually develop tertiary syphilis. This is characterized by development of goma or diffuse inflammatory lesion. The syphilitic lesion characteristically affect the proximal aspect of the aorta and can result in atypical aneurysm. Remember this for pathology. The actinomycosis are facultative anaerobe and may be difficult to culture. Direct visualization of the organism and the sulfur granules from the lesions themselves is the easiest way to make a diagnosis. And it's a very common recall in the exam, and the only characteristic thing in the question will be the sulfur granules. It remains as a differential of conditions such as hidradenitis suppurativa, particularly if it's occurring in odd location and with deeper abscess than usual. Ascaris lumbricoid, the funny worm. The infection with Ascaris lumbricoid usually occur after individuals have visited places like sub-Saharan Africa or Far East. Unlike Ankylostoma duodenale infection, there is usual evidence of both worm and egg in stool. The absence of pruritus makes entropius less likely. The presence of coughing may be due to migration of the larva through the lung. Let's have some notes about some parasites. Ankylostoma duodenale. It's a hookworm that anchors the proximal small bowel. Most infections are asymptomatic, although may cause iron deficiency anemia. So when you read Ankylostoma duodenale, remember iron deficiency anemia. When you read iron deficiency anemia, think of Ankylostoma duodenale. Larva may be found in stool, left at ambient temperature, otherwise infection is difficult to diagnose. Infection occurs as a result of cutaneous penetration or migration to lung, cough up to then swallow. Treatment is mebendazole, just like the Ascaris, and in Trubias Vermiculitis, all by mebendazole. The difference is the mode of transmission and how to diagnose. The larvae of the ankylostoma will be in the stool. Regarding Ascaris, due to infection with roundworm, not a hookworm like ankylostoma, but roundworm is Ascaris. The Ascaris lumbricoid infection begins in the gut following ingestion, then penetrating the duodenal wall to migrate to the lung, coughed up and swallowed. Cycle begins again. Diagnosis is made by identifying of the worm or the egg within the feces, while the Ankylostoma duodenale can be identified by the larvae in the stool. The treatment, just like ankylostoma and the Entropius Ascaris, is treated by mebendazole. Entropius vermicularis. The Entropius vermicularis is common cause of pruritus ani. You will find the baby want to itch his anus. Diagnosis is usually made by placing scotch tape at the anus, or you can see it by your eyes if the mother is negligent. This will trap eggs when you put the tape, and even can see the worm itself. The treatment will be mebendazole, just like the Ankylostoma duodenale and the Ascaris. So let's remember that Ascaris may cause IO, or obstruction of any tube in our body, even the biliary tree. I have seen myself appendicitis due to Ascaris lumbricoides. Surgical jaundice, classified according to the origin of the jaundice cause. It is either prehepatic or hepatic or posthepatic. Prehepatic jaundice is caused by conditions that increase the blood hemolysis. Whatever causes the blood hemolysis is a prehepatic cause. While the posthepatic jaundice or obstructive jaundice happens when bilirubin can be drained properly into the bile duct or digestive tract because of the blockage. The most common cause of posthepatic jaundice are stones, hard calcium deposit, or anything that can block the bile duct, even Ascaris worm. Remember, hepatic jaundice happens when your liver tissue is scarred, damaged, dysfunctional liver, like cirrhosis. This makes it less effective at filtering out the bilirubin from our blood. Since it can't be filtered in our digestive system for removal, bilirubin builds up to higher level in our blood. Hope by those three voices you have cleared the terms of pre-hepatic, hepatic, and post-hepatic, especially if you are not a general surgeon. Let's apply the surgical jaundice on labs. We said pre-hepatic is a hemolytic cause. So the bilirubin will be normal or high, but the liver function like ALT or AST will be normal, as well as the alkaline phosphatase. In prehepatic hemolysis, the bilirubin will be high, but the liver function and the alkaline phosphatase will be normal. In hepatic jaundice, the cause in the damaged liver itself, of course the hepatic labs will be high, the liver function will be high, the ALT and AST will be high, the alkaline phosphatase will be elevated, but not to a very high level, and bilirubin will be high. The post-hepatic jaundice, which is an obstruction in the biliary, the bilirubin will be high, very, very, very high, especially the direct bilirubin. The ALT and AST, the liver function, will be moderately elevated from the feedback of the pressure. It can't drain its bile. And the alkaline phosphatase will be very, very high in the post-hepatic jaundice. Remember, in post-hepatic jaundice, which mostly obstructive jaundice, the stool will be often pale in color and the urine will be dark in color. Total parenteral nutrition is associated with jaundice, usually follow a long-term use and usually painless with non-obstructive features, often due to hepatic dysfunction and fatty liver, which may occur with long-term total parenteral nutrition. So, TPN can be associated with jaundice, remember, but it's not obstructive and usually painless. Here, we talked about the E. coli enterohemorrhagic strain and said that the O15-7 strain can cause hemorrhagic colitis and hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. But the hemolytic uremic syndrome occurs in children, not in adults. Typically develop this complication in children, not in adults, with the E. coli O15-7. The hemolytic uremic syndrome can be caused by the E. coli O15-7, but in children. Take care from the HBV and the HBV. The human papillomavirus is a thing and hepatitis B virus is another thing. The human papillomavirus is associated with cervical cancer, anal cancer, penile cancer, vulval cancer, and the oropharyngeal cancer. It's exclusive to the private areas. And he considers the oropharyngeal cancer with the private areas, especially the strain 16 or 18, human papillomavirus. The EBV, the Epstein-Barr virus, is associated with the Burkitt lymphoma and Hodgkin lymphoma, post-transplant lymphoma, nasopharyngeal carcinoma. So the lymphoma in general, Burkitt, Hodgkin, post-transplant, with the Epstein-Barr virus, associated with كمان nasopharyngeal carcinoma. Very famous question in the MRCS telling you about a young man who is readmitted following difficult appendectomy, and his wound is erythematous and the incision show foul smelling and pus is drained, asking you about the most common organism listed. The Bacteroides is commonly present in severe peritoneal infection, and as its facultative anaerobe may be present in pus, it has pungent aroma. So appendicitis, appendectomy, Bacteroides are common. Pungent aroma. Pungent means taste or smell. It gives a sharp sensation, and aroma distinctive taste or smell. Here about the Bacteroid have distinctive, distinctive smell, pungent aroma, distinctive smell, pungent aroma. Hepatitis B virus, very famous from the very first days in our medical college study days. Hepatitis B is double-stranded DNA virus. It is spread through exposure to infected blood or body fluids, including vertical transmission from the mother to the child. So, a hepatitis B infected mother will transmit it to her child. The incubation period is 6 to 20 weeks. Immunization against hepatitis B contains hepatitis B surface antigen, absorbed into aluminum hydroxide adjuvant and is prepared from the yeast cell using recombinant DNA technology. Most schedules give 3 doses. Most of you have this schedule, of course, 3 doses of vaccine with recommendation for one of booster dose 5 years following the initial primary vaccination. The risk group. We are the risk group. The risk group who should be vaccinated are the healthcare workers like us, intravenous drug users, and sex workers. Sorry to say that, but this is important to be stated. The intravenous drug users and the sex workers are risk group. The close family contact of an individual with hepatitis B, if he has a relative with hepatitis B, individual receiving blood transfusion regularly, even if the blood test is running on the RBC unit he is receiving. Chronic kidney disease, patients who are on dialysis, patients who may soon require renal replacement therapy, prisoners, and the chronic liver disease patient. In brief again, hepatitis B is double-stranded DNA virus, incubation period 6 to 20 weeks. Immunization against hepatitis B using hepatitis B surface antigen absorbed into aluminum hydroxide. The schedule 3 doses. Remember, management of hepatitis B. The B-gylated interferon alpha used to be the only treatment available right now. It reduces the viral replication up to 30% of the chronic carriers. A better response is predicted by being female less than 50 years old and low hepatitis B virus DNA level. To be non-Asian is considered a better response. HIV negative and high degree of inflammation on the liver biopsy. However, due to the side effect of B-glycated interferon, it's now used less commonly in clinical practice, and oral antiviral medication is increasingly used with aim to suppress the viral replication. Examples include lamivudine and tenofovir and entecavir. About the necrotizing fasciitis, that's important cornerstone to do debridement, but never attempt to primary closure after initial debridement of necrotizing fasciitis. Again, debridement is a cornerstone in necrotizing fasciitis, but never attempt to primary closure after initial debridement of necrotizing fasciitis. Penicillin is the antibiotic of choice for group A streptococcal infection. The PNF suggests stopping fluoxetine if streptococcal infection is confirmed in a patient with cellulitis due to high sensitivity. This should be balanced, however, with the variable absorption of phenoxymethylpenicillin. Cocci may be divided into alpha and beta hemolytic types. Alpha hemolytic type is the most important alpha hemolytic streptococcus in Streptococcus pneumoniae. Pneumococci is a common cause of pneumonia, meningitis, otitis media, even endocarditis with the Streptococcus viridans. While the beta hemolytic streptococci can be subdivided into group A beta hemolytic streptococci and B beta hemolytic streptococci. Take care, the beta hemolytic streptococci subdivided into A and B. Group A, most important organism is Streptococcus pyogenes. responsible for erysipelas, impetigo, cellulitis, type 2 necrotizing fasciitis, and pharyngitis, tonsillitis. So when you see impetigo, cellulitis, erysipelas, or even necrotizing fasciitis type 2, pharyngitis, and tonsillitis, think of streptococcal pathogens. Group A, beta hemolytic streptococci. The immunological reaction can cause rheumatic fever or post-streptococcal glomerulonephritis, and even erythrogenic toxin can cause scarlet fever. While the group B, beta hemolytic streptococci, causes Streptococcus agalactica, may lead to neonatal meningitis and septicemia. Again, streptococci, alpha and beta. The alpha, famous for pneumonia, meningitis, otitis media, even endocarditis by the Streptococcus viridans, while the beta hemolytic streptococci, group A and B, group A very famous for every surgeon, with erysipelas, impetigo, cellulitis, type 2 necrotizing fasciitis, the A group, the beta hemolytic A group, while the group B, Streptococcus agalactica, lead to neonatal meningitis and septicemia. This is a tricky question because he didn't state clearly that he gave antibiotic, but he depends upon the idea you must be knowing about the prophylactic antibiotic usage. Antibiotics aren't routinely administered during an uncomplicated cholecystectomy according to the UK guideline, unlike whatever you do in practice. So, from the indications for administration of a broad-spectrum antibiotic which may lead to Clostridium difficile include intraoperative bile spillage. So, delayed pelvic abscess followed bile spillage are extremely rare since most surgeons will manage these intraoperatively. And in here, in this question specifically, she will take antibiotic due to the bile spillage, and the diarrhea here is due to the Clostridium difficile infection. It's a confusing question, and I hope the question in the exam be more logic and clear. Clostridium difficile is a gram-positive root, often encountered in hospital practice. In the UK, it can be found in 3% of normal adults and up to 66% of babies. It produces an exotoxin which causes intestinal damage, leading to syndrome called pseudomembranous colitis. Pseudomembranous colitis, Clostridium difficile. The risk factors are broad-spectrum antibiotic, use of proton pump inhibitor or H2 receptor antagonist, contact with person infected with Clostridium difficile. The features are diarrhea, abdominal pain, raised white blood cells and TLC count and characteristic. If severe, toxic megacolon may develop. So Clostridium difficile may cause toxic megacolon. The diagnosis is made by detecting the Clostridium difficile toxin in stool, and you have to keep it in mind from the history of usage of the broad-spectrum antibiotic, and you will face it in your practice. And remember this, whatever your specialty, whenever you use antibiotic and the patient will complain about different bowel habits and different diarrhea bouts he is facing, this is Clostridium difficile. How to manage? First line therapy is oral metronidazole for 10 to 14 days. If severe or not respond to metronidazole, then oral vancomycin may be used. Patients who don't respond to vancomycin may respond to oral fidaxomicin. Oral fidaxomicin. So first metronidazole. If not responding, add to vancomycin. If not responding, add fidaxomicin. The patient with severe and unremitting colitis should be considered for colectomy. Yes, colectomy if severe and unremitting colitis. Take care. Very serious issue. Everybody goes to swimming pool to enjoy his time. But the doctor, when he sees the pool, he thinks of one thing, the giardia, because it's resistant to chlorination. And that's causes a risk to transfer in swimming pool. Giardia causes fat malabsorption. Therefore, greasy stool can occur. And it's resistant to chlorination, makes it liable to be transferred in swimming pool. Septic arthritis, most common organism overall is Staph aureus. In young adults who are sexually active, Neisseria gonorrhea should be considered. The management. Synovial fluid should be obtained before starting treatment. Take care. The intravenous antibiotic which cover gram-positive cocci are indicated. The PMF currently recommends fluoxacillin or clindamycin if penicillin is allergic. Antibiotic treatment is normal given for several weeks, from 6 to 12 weeks. Needle aspiration should be used to decompress the joint. Arthroscopic lavage may be even required. So take care. Septic arthritis, most common organism, Staph aureus. In young adults who are sexually active, consider Neisseria gonorrhea. Campylobacter jejuni, most common cause of acute infective diarrhea. It's a spiral gram negative root, usually infected cecum and terminal ileum. Local lymphadenopathy is common. May mimic appendicitis as it has marked right iliac fossa pain. Reactive arthritis is seen in 1 to 2% of the cases. This is good information about the Campylobacter jejuni, but in the exam he will tell you that someone has a milk or has a juice or any bottle in his hand and has been picked by bird. So remember, birds are recognized reservoir for Campylobacter jejuni. Take care. Consider Staph epidermidis for any implant you face, asking about the causative organism caused the infection over an implant. Staph epidermidis tend to colonize over plastic devices and form a biofilm which will allow colonization with other bacterial agents. They are difficult to eradicate once established, and the usual treatment is removal of the device. Osteomyelitis. It's an infection of the bone caused by Staph aureus and occasionally Enterobacter or Streptococcus species. In sickle cell, take care, in sickle cell, osteomyelitis is caused by Salmonella species, and the S with the S. Osteomyelitis in sickle by Salmonella, but in general, Staph aureus and occasionally Enterobacter or even Streptococcus. But in sickle patient, Salmonella is the cause of the osteomyelitis. Clinical features of osteomyelitis must be suspected in the patient when you see erythema or pain or fever. To investigate osteomyelitis, X-ray will show lytic center with a ring of sclerosis. Bone biopsy and culture can be needed to diagnose osteomyelitis. Treatment by prolonged antibiotic and sequestra may need surgical remove by drill. The orthopedic drilling of the bone with osteomyelitis, you will see a pus coming out of the bone. Yes. Regarding osteomyelitis investigation, the plain radiograph may be normal in early stages. If you are suspecting osteomyelitis and you want to document it by investigation, use MRI. It will give a clear image earlier. Quinsy usually occur as a result of bacterial tonsillitis, and the most common cause of bacterial tonsillitis is streptococcal organism. HIV seroconversion is symptomatic in 60 to 80% of patients and typically present as a glandular fever type illness. So someone will think of it like glandular fever or something. Increased symptomatic severity is associated with poor long-term prognosis. It typically occurs 3 to 12 weeks after infection. Features: sore throat, lymphadenopathy, malaise, myalgia, arthralgia, diarrhea, maculopapular rash may occur, and he is not even aware of his HIV probable to be infection. Even mouth ulcers, rarely meningoencephalitis. To be diagnosed, antibiotic to HIV may not be present, but HIV PCR and P24 antigen test can confirm the diagnosis. Most common accurate test is HIV antibody test. Usually consists of both screening ELISA, enzyme-linked immunosorbent assay, the ELISA, enzyme-linked immunosorbent assay, and confirmatory test, which is a Western blot assay. Most people develop antibodies to HIV at 4 to 6 weeks, but 99% do by 3 months. B24 antigen test usually positive from about 1 week to 3 weeks after infection, sometimes used as additional screening test in blood bank. So in simple, HIV antibody test is the most common and accurate test, but it will appear 4 to 6 weeks after the infection. But the B24 antigen test will usually be positive from week 1. So for screening test, what you should do, the antibody or the B24 antigen, which is more fast, the B24. Cholangitis infection, most common organism is E. coli. Cholangitis, coli. E. coli, cholangitis. Remember, while the Enterobacter is occasionally cultured, is not the most common organism. So you may find Enterobacter, but E. coli the most common organism. And by the way, charcot is a surgical emergency. Patient will need biliary decompression and broad-spectrum antibiotic. Cholangitis is a combination of bacterial infection and biliary obstruction. Bacterial infection plus biliary obstruction equals cholangitis. Most common organisms are E. coli is the first. E. coli is the first. Then add whatever you know from Klebsiella, Enterococcus species, Streptococcus species, and the clinical feature are Charcot's triad: fever, pain, jaundice. Fever, pain, jaundice. Charcot triad: fever, pain, jaundice. Charcot triad: fever, pain, jaundice. Please, never forget, because if we add confusion and a hypotension, it's Raynaud's-Vented. Charcot triad: fever, pain, jaundice. Raynaud's-Vented, add confusion and hypotension. It can be investigated with ultrasound, which is the first line, then CT and ERCP may be the first line if high clinical suspicion and suitable for treatment, because ERCP is diagnostic and therapeutic. Can treat it. Treatment of cholangitis. ERCP usually after 72 hours of antibiotics, and percutaneous transhepatic cholangiogram and biliary drain may be needed. Mrsa, methicillin-resistant Staphylococcus aureus, the first organism which highlighted the danger of hospital-acquired infection. Mrsa should be screened in all patients awaiting elective admission. In UK, all emergency admissions are currently screened. If you want to exclude some patient, exclude the day cases or pregnancy or ophthalmic patient and mental health trust patient. But the patient should be screened for Mrsa by a nasal swab and skin lesion or wound. The swab should be wiped around inside the rim of the patient's nose for 5 seconds. The microbiology form must be labeled Mrsa screen. Suppression of Mrsa from the carrier by nasal mupirocin, and this is a very famous recall, mupirocin 2% for 5 days, and skin chlorhexidine cloconate for 5 days, and be applied all over, particularly the axilla, groin, and perineum in the hidden places. Vancomycin and teicoplanin used in the treatment of Mrsa. Rifampicin, macrolide, tetracycline, amyclopyrazide, and clindamycin can be used, but some strains may be resistant to them. Relatively new antibiotics like linezolid and quinaprostine and dalfoprostine and tiglycine have activity against Mrsa, but should be reserved for resistant cases. Or if we have them resistant to Mrsa, may God help us all. Take care when you read the question and see the swimming pool, and you want to jump to the giardia when you read watery diarrhea. But remember, the watery diarrhea in a patient who had cadaveric renal transplant, he is immunocompromised. So think of Cryptosporidium, which is associated with infection, particularly in those immunocompromised patients. Epstein-Barr virus may cause generalized lymphadenopathy. This may be associated with splenomegaly. This enlargement has been associated with spontaneous rupture. Epstein-Barr virus associated with nasopharyngeal carcinoma in the nose. The Epstein-Barr virus, nasopharyngeal carcinoma, while the human papillomavirus 1618, oropharyngeal cancer. Oropharyngeal cancer for human papillomavirus. Valsalva maneuver is performed by moderately forceful attempt to exhalation against a closed airway. You close your mouth and nose and try to exhale, just like the person want to defecate and try to make it forceful down there. He shut out his mouth and nose and try to strangulate and, yes, exhale without expiring his air out. So the pleural space will be negative at the end of expiration, at the end of inspiration, and if the patient has tracheostomy, and when taking a deep breath even, but during Valsalva maneuver, the pleural space is not negative with respect to atmospheric pressure. The complication of acute pancreatitis is very crucial in the exam. It may cause shock and renal failure, hypoxia, hypocalcemia, hypoalbuminemia, but will cause hyperglycemia. It will cause hypocalcemia by sequestration of calcium in fat necrosis, hypoalbuminemia by increased capillary permeability, while hypoxia due to ARDS, acute respiratory distress syndrome, due to microthrombi in pulmonary vessel, but hyperglycemia is due to the disruption of pancreatic islets. All of this will share to form shock and renal failure. The pancreatic failure is associated with leakage of fluid of the pancreatic bed, also ileus with fluid-filled loop of bowel leading to pre-renal osteomia, and then acute tubular necrosis. So hypocalcemia due to sequestration of calcium in fat necrosis. Again, pancreatitis will cause hypocalcemia. Very important and very common recall in the exam. Hypocalcemia may be found because of sudden removal of large amount of calcium from the extracellular fluid because of the impaired mobilization or result of calcium fixation by fatty acid liberated by increased lipase action on triglyceride. Again, hypocalcemia may be found because of sudden removal of large amount of calcium from the extracellular fluid of impaired mobilization or result of calcium fixation by the fatty acid liberated from increased lipase activity on triglycerides. Hypoproteinemia in pancreatitis due to mainly notable loss of plasma into the peritoneal space. Bitemporal hemianopia. It's a medical description of a type of partial blindness where vision is missing in the outer half of both right and left visual field. It's usually associated with lesions of optic chiasm. And when we are talking about optic chiasm, we have to think of the pituitary gland, the area where the optic nerve from the right and left eye cross near to the pituitary gland. Acromegaly is rare, slowly progressive acquired disorder that affect adults. It occurs when the pituitary gland produces too much growth hormone. The pituitary gland is a small gland that located near the base of the skull that stores several hormones and releases them into the bloodstream as needed by the body. And it's related to the optic chiasm. Take care. When a case comes in the exam asking you of the cause, collect all the puzzle. He is telling you a man on insulin without food and gone to an operation. And after that, he is tachypneic, not bradypneic. He is tachy, not brady. So, it's not the morphia. Morphia will cause respiratory depression induced. But This is typical hypoglycemia, especially when he is talking about convulsion and confusion as well. The structure pierced by the lumbar puncture is always asked in the exam. So, let's remember from outside, inside. Skin, supraspinous ligament, interspinous ligament, and ligamentum flavum. Again, from the skin inward, skin, supraspinous ligament, interspinous ligament, and ligamentum flavum. Regarding the CSF, bacterium will cause neutrophil, viral will cause lymphocyte. The end of the bacterium is N, will cause neutrophil. The viral ends with L, would cause lymphocyte, just in case you forget it frequently, just like me. Viral, lymphocyte, bacterium, neutrophil. The boundaries of femoral ring is important because through the femoral ring exists the femoral hernia. So when you ask it about the femoral ring or the femoral hernia, they are almost the same. The same regarding the anatomical site, not the same thing. The hernia is a protrusion, okay? Through a defect in a sac. Take care. So the boundaries of the femoral ring again. Anteriorly, the inguinal ligament. Posteriorly, the ligament of Cooper, which is the pectineal ligament as well. Medially, the lacunar ligament, Gembimat ligament, is the medial part. While laterally, the septum, which separates the femoral canal from the femoral vein, the Silver's fascia. Okay? The MRCS examiners used to play with words, so take care which is related to which. He is asking about the brachial artery related to the median nerve or the median nerve related to the brachial artery. Because if we said that the median artery related to the brachial, it will be lateral, anterior, the medial. And reverse it if he is asking about the brachial artery. Okay? In obstructive jaundice, you have to know the Charcot triad and Reynolds mentat. Charcot triad is pain, jaundice, and fever. When you add low blood pressure and tachypnea, hypotension and tachypnea, and altered mental status, which is confusion, so it's Reynolds mentat. So Charcot triad, pain, jaundice, and fever. While Reynolds mentat, altered mental status. Shoulder abduction, the supraspinatus initiates the abduction, then the deltoid continues up to 90 degrees. Above 90 degrees, the trapezius and serratus anterior go with the abduction above 90 degrees. So, supraspinatus, deltoid, and trapezius with the serratus anterior share in the abduction of the shoulder. The supraspinatus initiate, deltoid continues up to 90 degrees, then above 90 with the trapezius and serratus anterior. Hope it's clear now. Increased intracranial pressure will manifest by Cushing triad, hypertension, bradycardia, and bradypnea. Hypertension, bradycardia, and bradypnea. In increased intracranial pressure, the rise in hypertension, the rise in blood pressure is due to sympathetic stimulation related to intracranial pressure. Acidosis with hypoxia and low base excess with low bicarb, this means metabolic acidosis. Remember, the sinoatrial node, the SA node, has a major blood supply from the right coronary artery. That's why in inferior MI, bradycardia would occur rather than tachycardia. So, in right coronary artery is the main blood supply of the SA node. That's why in MI, bradycardia would occur rather than tachycardia. Remember, the psoas major originates from the transverse process of L1 to L5 and the bodies of T12 to L5 and intervertebral disc below bodies of T12 to L4. The insertion, middle surface of the lesser trochanter of the femur. The psoas major is major, but yet it inserts in the middle surface of the lesser trochanter. The psoas major, the lesser trochanter. And its action is to flex and laterally rotate the hip. Flex and laterally rotate the hip. The nerve of psoas major, the innervation by the anterior primary rami of L1 and 2. Remember the order and the renal pelvis. VAP, vein, artery pelvis from anterior to posterior. So take care, what is the question asking? Is he asking the patient lying prone or supine? He is asking to look from behind or anterior. Again, VAP, vein artery pelvis, from anterior to posterior, from ventral to dorsal. The accessory nerve innervates the trapezius and sternomastoid muscle in the neck. Its injury may cause pain and winging of the shoulder blades and weakness of the trapezius muscle. Again, it will cause winging of the shoulder blade. The posterior triangle of the neck. The boundaries are posterior border of sternocleidomastoid, anterior border of trapezius, and the mid-third of clavicle. The shape is spiral. The roof, investing fascia, platysma, external jugular vein. The floor, prevertebral fascia, and covering muscle, subclavian artery, francobrachial plexus, and cervical plexus. The contents: the arteries, occipital, superficial cervical, suprascapular. The vein, transverse cervical, suprascapular, external jugular. The nerve, very important to remember, the branches of cervical plexus and especially the spinal root of accessory spinal nerve. Again, the spinal root of accessory spinal nerve is in the posterior triangle. Very common question in the exam and very common to be asked for. The muscle about the omohyoid with its sling, lymph node, occipital, rubella scalp infection will cause rubella, occipital lymph node enlargement, and the supraclavicular part of the deep chain. The surface anatomy of the spinal accessory nerve, nerve number 11, in posterior triangle. Ear loop to 5 cm up to trapezius, or 1/3 down posterior border of sternocleidomastoid to 1/3 up anterior border of trapezius. The pulmonary artery is derived from the aortic arch number 6. The pulmonary artery embryological origin is the aortic arch number 6. The 6th aortic arch provide the right and left pulmonary artery embryologically. Friends, when we are talking about the aldosterone, think only about sodium and potassium mainly. Again, when you hear the aldosterone leads to maintenance of intravascular volume or oliguria through sodium and potassium. And here we know that sodium and potassium are being regulated by the aldosterone in the collecting tube. The subclavian artery is very important because it supplies thyroid, breast, diaphragm, brainstem, and upper limb. Yes, the subclavian artery, this artery supplies the thyroid, the breast, diaphragm, brainstem, and upper limb. So it's a little bit important, right? The annular pancreas usually constrict the second part of the duodenum. The annular pancreas usually constrict the second part of the duodenum. Remember this. Remember, we have mainly 3 types of gallstones: mixed, pigmented, and cholesterol. The mixed, usually brown in color, contain cholesterol and calcium and bilirubin from the biliary stasis. The cholesterol stone caused by imbalance of composition of improbable gallbladder empty, yellow and green in color. And this is the most common type of the gallstone. The cholesterol stone is the most common, up to 80%, while the pigmented stone, the dark black color, is mostly due to high content of bilirubin in the blood due to hemolysis or anemia. The sickle cell anemia and the hemolytic anemia and the Crohn's disease are mainly the main cause for dark color black gallstone. This wisdom, the conjugated are friendly, are colored and mixed, yellow, green, brown, but the unconjugated bilirubin is bad. We love to be together, we love to be conjugated, but the unconjugated is dark and black, and this is due to hemolysis. Yes, the medicine is full of wisdom thoughts. Take this wisdom. It's very important to know that in phalangeal incision, we only cut the skin, then the fascia and anterior rectus sheath, but the muscles, the rectus muscles are retracted. Then the fascia transversalis will be cut to expose the peritoneum. We don't cut the rectus muscle, we only retract it, even in phalangeal during CS incision. And take care, there is no posterior rectus sheath at this level. Post-splenectomy, you will notice low retics, high platelets, Howell-Jolly bodies, and Heinz bodies. 3H, high platelets, Howell-Jolly bodies, and Heinz bodies, but low retics. Remember, warfarin inhibits factor 1972, factor 10972, 1972. Its antidote is vitamin K, traced by INR, because it works on both intrinsic and extrinsic pathway.